talk is about lower limb complex deformity correction in an acute setting using polar screw guided intramedullary interlocking devices. Dr. Zamir's talk was very informative and it has made my life a lot easier. I'm sure by now you know about CORA, about the location of deformity, multi-apical deformities and oblique plane deformities. So, very often we encounter deformities like this, in which either there are skew deformities or there are multi-apical deformities, in which we have to apply very complex Ilizarov frames or we have to resort to other modalities. So in order to correct these deformities in a very reasonable way, in an acute manner, this is the technique that I use. So we all know there are many ways of correcting a deformity. It can be, implant can be an external device or an internal device. We can either acutely correct a deformity or gradually correct it. We can use Ilizarov frame, Taylor special frame. There are a lot of things that can be used. And I'm sure we all are well aware of the use of polar screws. And in trauma setting, whenever there is a fracture near the metaphyseal area, we use polar screws to guide our intramedullary device so that the deformity is not formed and correct reduction is achieved. Using the same principle, I operated upon 19 patients. I operated upon 25 or more patients, but the study included 19 patients when the deformity in one bone ranged from 18 to 32 degrees. In this technique, a standard standing scanogram was taken. All the parameters were assessed and measured, and magnitude and location of deformities were evaluated. And then in an AP view, this is how the polar screws were planned. As we all know that the lateral distal femoral angle anatomical is 81 degrees and a medial proximal tibial angle is, and the mean is 87 degrees, and a lateral distal the lateral distal tibial angle is about 89 degrees. So if we use an intramedullary device and we guide the nail along these said angles in the metaphyseal area, the nail will correct the deformity on its own. So this is the planning that I do. It is very simple. I draw a line and an imaginary 81 degrees line in the lateral distal femoral angle. And I have to make sure that the nail passes along this line. So, yeah. So, as we all know, if we want to nail this femur, it will tend to go to this position. So we have to make sure that the nail goes along this 81 degrees and lateral distal femoral angle imaginary line. So I will pass a polar screw, which is just medial to this point at a reasonable place. And then, so since it's a metaphyseal area, and once we are correcting the deformity, the forces will tend to push the nail here. So in order for it to not do that, I'll place a screw over here as well. And if there is a deformity in the sagittal plane, I'll pass a screw in the lateral plane as well. And all I need to do is where this line touches the cortex, I'll just do an oblique osteotomy just proximal to that part, and the nail will correct the deformity on its own. And if it's a multi-apical deformity like in this side, I have directed the nail in this place, and in the diaphyseal area, wherever the cortex touches, I'll do an osteotomy like we are doing shish kebab osteotomies. So another case, similarly, as you can see, it's an oblique plane deformity, and the deformity is in two planes. It is in the lateral plane as well. So again, I'll just plan an 81 degrees line. I'll mark the places where I want to put my polar screws, and the nail will do the rest. After reaming, screws are passed, and after the surgery is done, the patients are allowed knee range of motion exercises from the next day, and weight bearing is allowed at 6 weeks. If the patient has deformity, like in this case, in the tibia and in the femur, using a same medial parapatellar incision, both the deformities are corrected. A retrograde nail is passed in the femur and an antegrade nail is passed in the tibia. So in this study, the age range was from 14 to 38 years, and 62% patients had a bilateral deformity, 54% patients had deformity in both femur and tibia bones, so they needed antegrade tibia and retrograde femur. And all the deformities were corrected within 5 degrees of mean reference values. And one patient who had a valgus deformity in the tibia, who had the deformity of about 20 degrees, he developed a foot drop. And in one patient in which there was varus deformity of tibia of about 25 degrees, there was loss of correction because I did not pass a proximal lateral screw. So this had to be revised. So I'm going to show you a few cases. This is the case which I shared with you earlier. As you can see here, a line along this line the nail was passed, 2 screws were passed, and here it says the deformity was distal. A distal screw was passed to direct the nail in the correct trajectory, and a lateral distal femoral angle of exact 81 degrees was achieved, and an MPTA of 91, and again a lateral distal tibial angle of normal range was also achieved. As you can see, and since it's a percutaneous osteotomy with very minimal destruction of soft tissues, these osteotomies heal very well, and you can see the union in start of union in 6 weeks. The case which I shared earlier, this patient had a deformity of about LDFA of 47 degrees on the right side and 54 degrees on the left side. This patient actually needed 3 osteotomies in his femur, and his lateral distal femoral angle of 82.4 degrees was achieved. And on the other side, again 3 osteotomies were needed, and 85 degrees of lateral distal femoral angle was achieved, as you can see clinically. And in this case, this is a case of windswept deformity. There is valgus on the right side and varus on the right side. Again, this patient needed osteotomies in his femur and tibia. After correction, 78 degrees of lateral distal femoral angle was achieved, and on the other side 82 degrees, 86 degrees of medial proximal tibial angle, and since the corner was both proximal and distal, it was a multi-apical in the tibia, 89 degrees in the proximal and 90 degrees distally was achieved. So in conclusion, this is a very relatively simple technique for correcting complex deformities. You just need to understand the basics of deformity correction and know how to pass the polar screws, and your intramedullary device will do everything. It will correct the deformity for you. Thank you so much.